Hey, good morning, everyone. Let me know if you can hear and see me. I'm We'll get started here in just a few minutes. Questions, you can post them up here on the chat. Perfect. Thank you, Dallas. And the sticky board's there too. It's always a great place to be anonymous if you prefer to interact that way. No problem there. If you guys are reviewing on campus, how many people are in the room, just out of curiosity, if you don't mind? Thirteen of us right now is pretty good. Okay, well, in the interest of time, let's go ahead and get started here. Okay, so we finished up talking about the antidepressant drugs that we were covering last time. Now I want to switch gears a little bit and talk about bipolar disorder and how we can help to manage that. Of course, you know that we're going to find that these patients will cycle sort of between the manic and the depressive phases there. You know, severity can certainly vary amongst each type of patient there in terms of how manic they get. And frequently you're going to find compliance is a big challenge here because frequently when they're in their more manic phases, they feel good and they don't feel like they need to take any medications. And so that can lead to a lot of, you know, issues in terms of them staying compliant with their medications, which are usually needed lifelong in a lot of cases there. Of course, if you have a patient presenting any sort of mania, you want to make sure that it's not something else that is, you know, more easily identifiable and fixable, such as like, you know, electrolyte disturbances, alcohol withdrawal, things like that. These are just a few on that list of things that should be in your differential when someone's presenting in a sort of quote unquote manic sort of, you know, mindset. Our goals here, once we've kind of ruled out that other stuff and we think this patient does have bipolar disorder, is to try to keep their normal psychosocial functioning or as close to normal as possible. If we can try to have them maintain their normal relationships and continue to be able to, you know, maintain gainful employment and retain their relationships and things like that, that's going to be very helpful. and then try to maximize that adherence, because that's a lot of the reasons you'll see them relapse is when they go off their meds because they feel good, they don't feel like they need it, and like I mentioned before. And if we could try to minimize the adverse effects they're going to experience, because they tend to be pretty myriad here, and then help to deal with any sort of like their compulsive habits that they have that may go along with that mania, so things like substance abuse, gambling, things like that. If we can avoid those, that would be great as well. In terms of medication, first off, sort of the most kind of widely used for a long time, maybe not nowadays so much, was lithium, which you could actually find in 7-Up back in the day. Thought it'd be lifting up your spirits a bit there. But also kind of funny that they call it slenderizing, probably some of the diuretic effects that the drugs can have, which we'll mention here just a little bit. But nowadays, 7-Up is free of lithium as far as I know. We don't really know how it works, but we do know that it probably has something to do with things like gene expression, maybe modifying things like neurotransmitter effects, neurotransmitter release. But we certainly do know its kinetics very well, and in fact, it works a lot like sodium in the body, and frequently the kidneys cannot tell the difference between lithium and sodium, and that actually makes sense if you look at them on the periodic table, which I'm not going to bore you with now, but you'll see that they actually are pretty close to one another, and so the kidneys can't tell the difference. And that'll be important in terms of the kinetics, because if your body's in a state where it wants to get rid of sodium, it's going to get rid of lithium. If it's in a state where it's holding on to sodium, it's going to hold on to lithium too. And that's important because this is a narrow therapeutic index drug, and if the levels get too out of whack, that can be a big reason for patients experiencing some pretty serious side effects. This can be a potentially very dangerous drug if not used responsibly. You'll still see this used in a lot of cases for mood stabilization in these patients here. These drugs we're using to control the manic phase of bipolar disorder, we typically call mood stabilizers. So you may see them used for other things like oppositional defiant disorder. They kind of just take the edge off in terms of more of those sort of manic sort of symptoms there. It doesn't do anything for depression. It just treats the manic symptoms, hopefully prevents them from happening here. And again, things like reducing the number of episodes, reducing suicide risk, all very helpful for these patients here, obviously. Here, as I mentioned, serum monitoring is really important. However, if patients are non-compliant, they're not following up, then that can be a challenge. And you can see the range here is pretty narrow, about 0.5 to 1.2 milliequivalents per liter. So not a whole lot in either direction, and you have either too little effect or you have way too much, which can lead to a whole host of problems, which we'll see here in just a moment. Again, I'm not going to ask you specific, levels on the test, which is, what is normal, what's abnormal. I may present to you a level and then give you what the normal is and make you do an interpretation to say, okay, this is too high, so what should we do with this now? Things like that I might ask in terms of more of application rather than just strict memorization of the levels. Anyway, a lot of patients are going to have adverse effects from this, which is why we're sort of now moving away from it in the recent couple of years and to other medications here. You'll see there's a lot of GI distress that comes about from this. Having the extra lithium, which acts as a sort of an osmotic laxative, almost can cause diarrhea, things like muscle weakness. And then you'll see a lot of effects like affecting the body, just like kind of sodium would, where you can see things like polydipsia and nocturia that can happen there. So it's almost like an increased sodium load. You can see affecting this. Chronic effects too are going to be kind of problematic, including this kind of resting tremor that they're going to have, and about half of patients are on lithium chronically. This can be blocked by either using things like long-acting formulations or like a beta blocker. Beta blockers tend to help pretty well there. Oh, it said week 7's not showing up on your Blackboard. Okay, I'll fix that. You should still have this lecture up because did you do the quiz? After 3/8/21, so that was yesterday. Let's see that. Try now. You should be able to see it. If not, let me know. Anyway, other issues you can run into here as well include things like nephrogenic diabetes insipidus. This is actually as a result of the effect that lithium has in terms of making your Yeah, I fixed that due date, so it should be fine there. But I removed the thing, so um, the requirement there, so you should be able to see week 7. Anyway, we guys got here to the YouTube stream, so I'm assuming you found something, a link. But anyway, other things you can run into is that the kidneys can affect, or the lithium can affect the kidneys in terms of its responsiveness to ADH or antidiuretic hormones. So that's why it causes a diabetes insipidus, which causes basically to lose lots of dilute urine there. We actually treat this with loop diuretics and thiazide diuretics, which seems kind of counterintuitive, but it has to do with its effects on kind of sensitizing the macula densa in the kidneys and allowing the body to become to be put into a more sodium retentive sort of state there. But anyway, so just be aware that that can be a potential side effect of lithium since it's pretty unique. Other things like nephrotoxicity can happen here, and hypothyroidism, since lithium can actually interfere with that thyroid hormone synthesis. That's a problem too, because these patients are frequently depressive as well, and so this can, hypothyroidism can certainly mimic depression. So that's one thing you really want to be watchful for there. So other things you're going to find in terms of interactions, there are going to be a lot of pharmacokinetic interactions. So anything that puts the body in a sodium retentive state is going to make you hold on to more lithium, which is going to cause those levels to rise and can be responsible for a lot of the neurotoxicity we'll see there. So things like dehydration, sodium restriction, heart failure, anything like that will cause the kidneys to hold on to more sodium, right? Because it's trying to increase blood volume and trying to keep that volume there. So it's going to lead to high levels of lithium, which is not great. This leads to a lot of drugs causing kind of a similar effect. So things like diuretics, things like NSAIDs, ACE inhibitors, all of that's going to bump their levels up. I can't tell you how many cases I've seen come into the hospital for neurotoxicity related to lithium or elevated levels. And it had to do with the fact that they just started an NSAID for an injury or something. And so it bumped their levels of lithium. They end up getting them in trouble from that standpoint. Now, lithium being a pretty simple ion, it doesn't get metabolized. It just gets excreted through the kidneys. So really, kidney function is the biggest thing to watch for. And there's no real CYP interactions to worry about since it doesn't get metabolized. So nowadays, what you're going to see more frequently are going to be the anticonvulsants for bipolar disorder. This includes things like valproic acid. We've seen these in the neurology section, so I don't have to go over these too in depth, but we'll talk about them in terms of their use for bipolar disorder specifically. We'll see here that now this is probably being prescribed most often, I would see, because it tends to be best tolerated by most patients. You don't have as much monitoring and as much issues as you're going to see with, as many issues as you'll see with lithium. And so we can either use this for like acute bouts of mania or for more chronic therapy, which is where you'll see it used pretty often. And how it works for bipolar disorder, again, we don't really know the full story there. Probably has something to do with sort of stabilizing some of those hyperactive neurons there. And just be careful, because if you see this used when in conjunction with other medications, which may be required for more difficult to treat cases, you will see increases in side effects as a result of that. Just remember things like, GI distress, certainly can see a lot of that, sedation, because again, just like we mentioned it with the seizure management there. And just look at liver function tests. Watch out for their ammonias, because that can spike for when they have too elevated levels of valproic acid. And then we'll, as mentioned, monitoring. We will monitor the range for this. This one can range pretty widely depending on the patient and kind of what they tolerate, since this is pretty well tolerated. So I've seen people be up, close to 200 mics per ml. That's just what works for them. So it really just is going to be pretty patient specific. And again, just remember to follow up on those liver function tests, because that's going to be a big thing you have to monitor for. It might be the reason why you have to stop treatment, is if their LT start to bump on you. Carbamazepine is also used, maybe not as like first line, but maybe used as an add-on sort of agent there, or maybe as an alternative to valproic acid. Again, probably some of its anticonvulsant effects also work for these manic symptoms here. And again, in terms of monitoring, we'll still do serum monitoring with this. But again, you want to look for things like sodium levels. Remember, we talked about SIDH is possible here. This and Oxcarbazepine, you can see the same thing. Looking for cardiac conduction changes, so you can monitor the EKG with this to make sure there's no things like QRS prolongation, things like that. And this one is going to have certainly a fair amount of CYP interactions, just like we saw with valproic acid back in the neurology section. That can cause a lot of CYP interactions. Here, this also induces CYP3A4, so you can run into issues of either affecting other anticonvulsants or things like oral contraceptives not being as effective. That can be really important too, because some of these manic patients may participate in sort of high-risk activities. So things like, say unprotected sex, and if their oral contraception is not working as well, there could be a risk for things like pregnancy. So these are things you want to educate on and be aware of. You may require alternative forms of contraception, which we'll talk more about in the OB-GYN section later on there. Oxcarbazepine, generally a little bit better tolerated than carbamazepine. It's just you have to watch the sodium much more closely because of the fact that SIDH is much more likely. And one of the benefits of Trileptal is there's actually no serum monitoring for the actual drug level itself. You can stick to pretty standard doses and just see how the patient's responding, which is helpful. Again, you can see some interactions here, things like induction of CYP3A4. So anytime you're adding on these new medications, just make sure to check their drug list, make sure to go through an interaction checker to see if you're going to be sort of affecting any of their other drugs, and can adjust based off of that. Lamotrigine is another good one we use as a mood stabilizer. I see this used frequently, especially with adults, especially if they have things like jobs and things they have to go to, so that way they're not becoming too sedate as compared to things like Valproic acid or Carbamazepine. So that's one benefit there. One thing I'll see pretty frequently is Valproic acid plus Lamotrigine. Just be really careful when you combine those two, since Valproic is going to decrease the clearance of Lamictal, and so you have to start at like half the normal dose of Lamotrigine and then kind of titrate from there, since you're going to find that it just takes longer for it to be metabolized and be eliminated. Other things you can see here is the rash and pruritus, like we mentioned back in neurology. Again, any new onset of rash, blisters, anything like that, mucous membranes being affected, skin being affected, they need to stop taking Lamotrigine immediately and have them come in to be evaluated, just because of that risk for Stevens-Johnson is particularly high for Lamictal. Certainly can happen with other things like Carbamazepine, but it's most notable here, I think, with Lamictal. So generally speaking, you're going to start off with a mood stabilizing agent there, with usually valproic acid probably being most often, lithium, valproic acid maybe, or lithium or carbamazepine being used as like second line agents there. Or we'll look at some of our second generation antipsychotics. That's that SGA there. We'll look at these in more detail in just a moment. And then if they're having acute issues like anxiety or agitation, you can add on a benzodiazepine. Something like some lorazepam or something like that can be useful for these patients as well. And for really severe cases, you may require two agents, but hopefully you will not get to that point there. If they're having inadequate responses with just one drug, you can add on something like, say lithium plus an anticonvulsant, or something like a second generation antipsychotic, or maybe two of the anticonvulsants. I probably see that more often. I see combinations of like Lamictal and valproic acid together pretty frequently for more difficult to treat cases, but again, every provider and patient is going to be a little different in terms of what their recommendations are. So that's it for bipolar disorder. Kind of quick, but most of those drugs we'd already covered before. But now I want to talk about the antipsychotics and treatment for schizophrenia. So when dealing with schizophrenia, you kind of have it broken up, their symptoms into three sort of categories here. You have the positive symptoms, which are things that are present which should not be. So things like having hallucinations, for instance. Like most of us don't have hallucinations normally. So that's something that's there that should not be. They will have the negative symptoms here, where things should be present but they're absent. So things like having a flat affect, right? That can be something that certainly I've been accused of, but basically, they should have some degree of affect. They should be able to respond to happy things and sad things effectively, but they have just really kind of a flat sort of mood. And then the cognitive symptoms too, including things like impaired memory, executive function. And so we're going to see here that with patients with schizophrenia, obviously, the most dangerous symptoms are going to be the positive ones, because that's where they're most likely to, say, harm themselves or harm others. And so when you think about a schizophrenic patient, quote unquote, either through media portrayals or things like that, you probably think about the positive symptoms most commonly, which, can be, as I said, kind of the most dangerous in the short term. But we're going to see that a lot of our initial treatments for schizophrenia weren't really, they were great at treating the positive symptoms, not great at the negative and cognitive. And that's what's going to be sort of a problem for these patients in the long term as well, when they need to like in relationships and go to work and do things like that. So we want drugs that are able to treat both, and so we'll see how that kind of evolved. Basically, with patients with schizophrenia, they have sort of a dysregulation of dopamine in various places like the frontal cortex and the nucleus accumbens and things like that. In our first set of drugs here, our first generation antipsychotics, they really worked by blocking D2 receptors. So they're blocking dopamine receptors, and that helped to decrease those positive symptoms. When you think about someone who's having like acute hallucinations and the devil's telling them to go and jump off a roof or something like that, whatever the case may be. That's a pretty extreme case, but whatever the case may be, those are those positive symptoms you're thinking about. And by blocking D2 receptors, that's going to have the biggest effect on those. We're going to see this is not great for the negative and cognitive symptoms, so it usually kind of zones the patients out pretty heavily when you're using those D2 blockers. But we'll look at some other drugs that may have better effects for that moving forward. With our antipsychotics, because we're blocking dopamine receptors there, you're going to get a lot of like very typical symptoms you would think of having a lack of dopamine, which we looked at specifically with Parkinson's disease. So for instance, one thing you're going to see here by blocking dopamine, you're going to see an increase in prolactin, right? Which is normally that hormone that causes breast development and for milk development and things like that. Well, that's going to cause problems in patients who are not actively nursing because they're going to see things like gynecomastia. You can see things like menstrual irregularities, infertility, issues like that. You're also going to see tremor that can develop here as a result of increased acetylcholine, just like we saw with patients with Parkinson's. And then the major limiting factor here is what we call the EPS, or the extrapyramidal side effects. These are those really classic Parkinson's-like symptoms that you can induce by giving these patients these drugs here. And basically it's due to dopamine blockade and that caudate putamen, just like we saw with Parkinson's. And so they can develop things like motor rigidity, tremor, catatonia in some severe cases here. And how this presents most acutely are going to be these dystonias. They can develop what we call these involuntary muscle contractions here. And it normally happens like in the face, the neck, or the tongue most frequently. And you'll see these patients will just kind of freeze up at their face and they'll just be like in this like grimace sort of picture. And again, you can Google videos, just look for acute dystonia antipsychotic, and you'll find plenty of videos that will show you what that looks like. I would demonstrate it here, but I don't want anyone to screen cap my face and then post up something funny of me later on, although I'm sure that happens. But regardless, those are one of the big things we'll see there. And in fact, this can present in different ways. I actually had one case of a 10-month-old who had gotten into his mother's antipsychotic drug, and they had such a severe dystonia, it was of the back actually. And so all of their back muscles were contracted and just arched up almost like a cat or something. And it was very, very painful for that child. And so we'll look at some ways we can treat that going forward, but it can be pretty problematic. Other things you're going to see includes an effect called akathisia, which is like really severe restlessness or agitation. I often describe it as like ants in the pants. Like you just really can't feel comfortable. You just don't want to sit still and get them to move around. That can be, somewhat problematic if they have like, especially like suicidal tendencies or something, because they may be more likely to act on them. And then chronically, we run into this problem of what we call tardive dyskinesia. And this is where basically you get this kind of chronic dopamine receptor upregulation. They get a hypersensitivity here. And these are going to be a potentially irreversible effect where patients will have things like inappropriate movements that they can't control. So things like chewing, licking movements, tongue protrusions. There's another one you can Google some videos on and see specifically what we're looking at. And this wasn't great because for a long time we just had the first generation drugs, and you kind of had to make a decision between treating their schizophrenia and getting tardive dyskinesia, or them having untreated schizophrenia and them not developing this. And so it can be pretty troublesome because there's not a lot of good treatments for this, unfortunately, and maybe irreversible. Other effects of the antipsychotic drugs include things like alpha-1 antagonism, which can lead to things like postural instability and hypotension. We'll have a lot of antimuscarinic effects. Some of these we've covered already. So remember, the mnemonic we use for antimuscarinic effects, including mad as a hatter, dry as a bone, blind as a bat, dry as a hot as Hades, red as a beet, all that stuff there. You want to think about as typical sort of antimuscarinic sort of effects. And while that may actually be good for some of the Parkinson's-like effects, like the acute dystonias, it actually ends up worsening the tardive dyskinesia in the long run, which is not great. So a lot of problems with the first-gen drugs, which is why we're sort of moving away from them now. Other problems you run into include things like histamine receptor antagonism, which means there's going to be a lot of sedation associated with these drugs here. I don't know if any of you have worked in the ER and seen a patient get a dose of Haldol, but it will certainly knock them down pretty quickly in terms of sedation. And we'll see some cardiac effects here, potentially things like QT prolongation. And kind of the most scary sort of acute thing that you can have develop here with our first generation antipsychotics are going to be something called neuroleptic malignant syndrome, or NMS. And so this is seen most frequently with the really high potency D2 blockers. And so I'll show you this in a slide here in just a moment. But the two sort of poster children for this includes things like haloperidol and fluphenazine, but it can occur with any of them. So it's just most likely with those two there. And basically, this is a life-threatening development that can happen here, where they can develop severe hyperthermia, altered mental status, hypertension, and they develop this classically described lead pipe rigidity. Anytime you hear lead pipe rigidity, you should be thinking about this for like board style questions or on rotations or something, because they basically, their muscles get locked up and they cannot relax them. So when those muscles are staying contracted like that for so long, they get very hot. They develop, they burn through their oxygen supply, so they switch over to anaerobic metabolism, so producing acid. And that can lead to that rhabdomyolysis, which can clog up the kidneys and cause renal insufficiency. So not great from that standpoint. So we'll look at some ways we can treat that as well. So there's a big list of first generation antipsychotics here. The ones that I've highlighted are the ones I'd like you to focus on in terms of memorizing for the testing purposes. A lot of these you may not see around nowadays, maybe more popular back in the 70s and 80s. But the ones I've highlighted here are the ones you're more commonly going to run into. So things like chlorpromazine, thyroidazine, prochlorperazine, perfenazine, fluphenazine, and then haloperidol. Here you can see their antagonistic effects at various receptors like D2, muscarinic, alpha-1, etc. And the big things I want you to notice here is not necessarily how many pluses are in each column, but sort of the balance here between dopamine blockade versus all these other effects you're going to see here. So typically, we're going to be breaking these up into our low potency D2 blockers and the high potency D2 blockers. The ones that are high potency are mostly going to be things like fluphenazine and haloperidol. You notice here, by having stronger effects at the D2 receptors, you're going to have lesser effects here at the muscarinic, alpha-1, etc. Excuse me. If you have low D2 effects here with something like chlorpromazine, you're going to have stronger muscarinic, alpha-1, and H1 blocking effects here. So it's sort of a seesaw pattern between these, where they're really high potency D2 blockers, they don't have as much effects on the muscarinic receptors and whatnot. They're low potency D2 blockers are going to have stronger effects on the muscarinic symptoms and things like that, which is actually can be a benefit of something like chlorpromazine, because these effects here help to mitigate this Parkinson's-like effect. So things like the extrapyramidal symptoms can be sort of treated by blocking these muscarinic receptors. So that's kind of one of the side benefits of using something like that. But if they're still having really difficult to treat positive symptoms, then you got to use something more with stronger D2 blocking effects, so something like a haloperidol. And just remember, the stronger the D2 blockade, the more likely to cause NMS and dystonia, as you're going to see there. Here is a slide that sort of breaks them down with the different and various side effects, so sort of track with what we saw on the previous slide in terms of pluses and minuses and things like that on the individual receptors. We'll cover the atypical drugs here in just a moment, but this is how you can kind of compare and contrast these different agents here to sort of see how the balance is. You can kind of pick one versus the other based off of what symptoms you'd be looking for. So as an example, if somebody was developing gynecomastia, they'd be much more likely with something like thyroidazine because it has more prolactin elevation than something like, say for instance, like haloperidol or something. So that's how we can kind of break these things down. You should be able to kind of parse that out on a test. So if I say, okay, which one of these is more likely to cause EPS, then you should know things that are high potency D2 blockers are more likely to cause that. Which ones are more likely to cause things like, orthostasis? Well, probably something with higher alpha-1 blockade. So those are kind of things I want you to take away from a slide like this. So the first gen drugs are good for the positive symptoms, but oftentimes you see a lot of the side effects, things like tardive dyskinesia, led to discontinuation. And again, the selection there is going to be based off the symptomatology. So if they're having a lot more of those positive symptoms, go with a heavier D2 blocking drug. You can see what we saw in those previous slides. How do we treat these side effects? If they're having an acute dystonia, if they're having akathisia, anything like that, we actually treat it with an anticholinergic. So just like we would see with Parkinson's patients, you can give them anticholinergics to deal with some of their symptoms. We can do the same thing here. We have three main agents: diphenhydramine, triacylphenidate, benztropine. For instance, with like that baby that I mentioned that got into its mother's antipsychotic and had that back arching at a piece of the tonus, which is the term for that, we actually gave them IV Benadryl, and that ended up relaxing the muscles within 20-30 minutes or so. So very helpful for that. If those fail, then you can use things like benzos, but it's often not needed. Most of the time, the anticholinergic is just fine there. For tardive dyskinesias, not a whole lot we can do for that besides things like drug discontinuation or drug holidays, which is basically where you give them a period of time where they're having a rest from the medication for maybe a couple weeks or a month or so, and you go back to it. Nowadays, though, we can just switch them to the second-gen agents. That's going to be the most effective way to manage their schizophrenia and be able to avoid that tardive dyskinesia. For the NMS, if that does develop, you typically want to discontinue the offending agent. Makes good sense. Cool the patient down with things like, cool IV fluids, evaporative dehydration, evaporative cooling, I should say, where you spritz the patient in the water and put a fan on them, and they'll dissipate the heat that way. And then we have a drug here called dantrolene or Dantrium. And this is actually a peripheral muscle relaxant, so it's gonna help to relax the muscle, prevent the breakdown, prevent some of the heat production. And you'll see this drug used too, especially like in surgery or in the ER for something called malignant hyperthermia, which is something that can develop with certain anesthetic drugs and a drug called succinylcholine. And if those still aren't working, then we can try a drug called bromocriptine, which we've talked about previously, as a dopamine receptor agonist to sort of replace what they're missing there. So if you have a dopamine blocker on board causing the NMS, then you give them a dopamine agonist to try to kick that off the receptor and reestablish kind of normal functioning. Here's a good table and kind of show you the different issues, kind of when it's likely to occur, incidents, things like that. The biggest thing I want you to be able to know is like what drugs are more likely to cause these different effects, and then how we would actually treat that. It's probably the biggest takeaways I'd want you to see from there. And again, if you can understand the mechanism, it will help you to identify which drugs are more likely to cause those effects there. Okay, so those drugs worked for a while, and again they were not the best because of the myriad side effects they had. But nowadays we have our second generation antipsychotics here, or otherwise known as atypical antipsychotics. Big benefit here is they have a lot fewer extrapyramidal and prolactin effects, and they also better treat the negative and cognitive symptoms. They have less tardive dyskinesia, and so because of all these reasons here, this is why you're going to be seeing these used first. Unless otherwise, so for some reason they can't take it. These are first line drugs for schizophrenia nowadays. So here you're going to see they have less D2 receptor effects here, so they're less positive for the positive symptoms overall probably than the first generation drugs, but they also have this effect here in the cortex, frontal cortex, where they can block serotonin receptors, and that actually helps to reestablish normal dopamine function throughout the brain, and that helps to deal with some of the positive symptoms, but it helps a lot with the cognitive and negative symptoms those patients will experience. Some of the side effects you'll see with these drugs in particular include weight gain. This is most likely with things like olanzapine and clozapine, and it's going to be lowest with drugs like ziprasidone and aripiprazole. I'll give you a table here in just a moment that has all the drugs. Typically, if these patients gain more than like 5% of their weight, then we typically consider that treatment failure, and we'll try to find something else. Are you going to have some patients that are so treatment resistant that they have to kind of deal with the weight gain? Yeah, I've seen a few cases like that, and that's not great. I've seen people balloon up 30, 40 pounds afterwards after starting these medications, which is unfortunate. But, if it's allowing them to, maintain some semblance of their normal lifestyle, then that may be a good trade-off for them depending on the case there. But to go along with that weight gain, you're going to see things like glucose intolerance. You're going to see things like hyperlipidemia. So you have to start to monitor and treat a lot of those chronic conditions in addition to the schizophrenia they're experiencing there. Clozapine is kind of one that we don't use unless everything else has failed, because it can have this effect of causing agranulocytosis. About 1 in 100 will experience this, and that's why we have to do monitoring for their CBC like weekly, which is not great. And it actually has like a provider patient registry, just like Accutane did. We talked about that in Derm. So patients that are registered for this just to make sure they get their monitoring. If they're not monitoring their CBCs like they should, then they don't get the drug, basically. So that can be a big challenge since compliance is already a problem with these patients anyway, typically. See some QT prolongation, so be careful if you're mixing and matching these with other drugs that can prolong QT. And then with the orthostatic hypotension, this can be quite common and more likely to be seen with elderly patients. But this does dissipate over the course of a few months once they sort of get used to the effects there. So we also have this black box warning. You want to be really careful and not use these in patients who are elderly that have dementia-related psychosis. We actually find an increase in mortality with those patients there. So we'll try to use other methods. Hopefully non-pharmacologic methods will work to kind of calm those patients down. But things like benzos might be a better option for them than going with an antipsychotic, since we do see mortality there. And then a lot of these drugs are quite sedating, so we may have them taken at nighttime to kind of help out with that. So things like quetiapine, which is Seroquel, olanzapine, clozapine tend to be the most sedating out of the bunch here. And then you will see some anticholinergic effects. Again, clozapine and olanzapine, which you're sort of noticing a trend here, are going to be the worst for this. So things like dry mouth, constipation can be pretty common there. And then seizures can be a risk for patients who have like a history of this. And again, clozapine and olanzapine have the biggest risk there. So here's the list of the atypical drugs here. You can see, again, a comparison between their different side effects. For the most part, avoid clozapine and olanzapine as best you can because the side effect profile is going to be just the worst out of all the bunch here. We have aripiprazole, we have clozapine, we have iloperidone, ziprasidone, paliperidone, olanzapine, quetiapine, risperidone, acinapine, and then lurasidone. This is a pretty popular category of drugs. A lot of new drugs are coming out periodically here. Since there's such a wide market for it, because it can help with things like bipolar disorder, it can help with treatment-resistant depression. So there's a wide market for this. So that's why I see so many of them that are out there. Again, you're going to see that typically most patients will start off on something like risperidone or aripiprazole because they have sort of the most favorable side effect profile. And then if that does not work for them, then they can try switching over to something else. And so just because one atypical doesn't work for a patient doesn't mean you can't use any of them. You can switch over to a different one in the same class and see how that works for them and kind of go from there. And again, here's another way we can kind of compare the side effect profile of the atypicals versus some of our first-gen drugs. Notice here that you're going to see much more of the anticholinergic effects, orthostasis with some things like clozapine, but really when you're looking at the EPS risk, much lower than you're going to see with a lot of these other ones here that are first-gen drugs because they don't really block the D2 receptors as strongly as your first-generation drugs do. So, okay. So what are we monitoring here? Certainly weight, blood pressure, glucose, lipids, all that good stuff because, again, we know the metabolic effects of these drugs chronically, especially the atypicals, is going to be the big thing we're monitoring for there. And just looking for the antipsychotic side effects like EPS, acute dystonias, NMS, things like that, you want to be monitoring for. So with acute treatment, again, you want to, if they're having acute positive symptoms, you want to treat that first. So you may require something like a first-gen drug. If the patients are kind of anxious or agitated, things like benzodiazepines like lorazepam, midazolam can be used to help out with that. And then you're titrating your dose to see kind of what the patient tolerates and kind of what's most effective there. And as I mentioned, if we don't see any improvement in about a month or so, then you can switch over to a different agent within the same category. And in general, start with a second-generation drug or an atypical drug first line, and if that doesn't work, then you can try switching within the class there. So if something like risperidone didn't work, then I can try something like quetiapine out, just knowing that it's going to have more sedation associated with it. So things like that. And then for patients, since compliance with antipsychotics can be a challenge, we do have some long-acting forms. This would be useful if patients have demonstrated that they do well with the oral form for a while. You can switch them over to a long-acting form. You wouldn't want to start out with this because many of these last for months, and so you wouldn't want to start a new drug in a dosage form that's going to last for several months because that can lead to side effects you just can't get rid of, because once you give something like this, then you can't really get rid of it, unfortunately. So again, let me know if you have questions on that. And then I think the last section here we'll have to finish up are going to be ADHD here. So basically we're going to find these patients have, difficult time concentrating, being able to stay on task, to get their schoolwork done, things like that. And so when dealing with these patients, you want to make sure you kind of identify kind of what the goals are, figure out what is most necessary. So whether it's, be able to pay attention in class, do their homework, etc. And then certainly non-pharmacologic methods, if you can do that at all costs, that would be fantastic with avoiding these medications here. But synergy can be found by using both of these, right? So making sure that you're introducing some of these behavioral interventions in addition to medications, and make sure there's kind of consistency amongst, the at home and in the school environment there. Savannah is asking, if a person is on a long-acting injectable and suddenly develops sudden worsened psychiatric symptoms, has an acute episode, would it still be okay to give them a benzo, take care of their acute flare? Yeah, that's totally fine. So let's say, for instance, you have someone who had Geodon is one that comes to mind that has a long-acting form. You can inject intramuscularly. If they're having acute symptoms in the short term, something that flared up, yeah, you can use benzo to help calm that down. Just be aware of that you can see some synergism between the sedating effects of those. But usually with the antipsychotics, they'll kind of get used to those effects over time, and so it shouldn't be too big of an issue. But just be cautious that they have like concomitant substance abuse issues, like opioids or alcohol or things like that. So just be cautious with that. And again, a lot of times patients may not be telling you when they're using some substances there, so that can be a challenge. Yeah, benzos are always fine to add on for acute sort of agitation, anxiety, symptoms like that. Sure. So, anyway, yeah, no problem. Thank you for the question. I appreciate that. Again, I'm sure many of you have other questions, so bring them up. I know I seem kind of maybe I'm intimidating. I don't know. I wouldn't say so. But if you have questions, always feel free to bring them up because I do appreciate that. Emily's asking, if a patient has acute positive symptoms, would you choose a second gen drug or the first, regardless of potential side effects? That's a good question. So that can be a challenge. I think a lot of it depends on the provider and sort of what they're used to. So I think about it from the ER setting because that's kind of where I come from. And so basically, what you're going to find with, say, a patient comes into the ER, they've been brought in via EMS, and they're having acute hallucinations. They are becoming very agitated. There may be a danger to themselves or maybe some of the staff members, things like that in the hospital. So for those kind of patients there, you want to sedate them because you need to be able to get them under control so that way they're not going to harm anyone. And so frequently chemical sedation is the means we're going to do with that because, getting those patients in physical restraints can be a challenge. It can also further exacerbate their symptoms. And so chemical sedation is used pretty commonly. So I think a lot of old school providers will utilize things like haloperidol pretty commonly, especially since you can get that intramuscularly. It's easier to get that rather than get an IV in someone who's acutely agitated. And so they use that. Nowadays, I'm starting to see newer providers be more comfortable with using some of the second generation drugs that you can administer intramuscularly. So things like Giadon, I see used in a lot of newer providers there. So there's not to say one's better than the other. Both of them are going to have pretty strong sedating effects when you give a big dose IM. So that's probably where you're getting even more symptom control, is just the fact that it's going to knock them out and they're going to be pretty sedate after that. I'll see a lot of times they'll talk about the B52, where it's a colloquial term we use in the ER for 5 of Haldol and 2 of Ativan. So B52, and that basically drops a bomb on them, and they're just going to be zonked out. They're going to be asleep for hours after getting a combo of that. So you can have someone who's going from acutely agitated to just snoring away in a matter of minutes after getting that kind of combo there, which is sometimes necessary, right? It's not ideal to have to use chemical restraints, but it is what it is when the patient's actively fighting your staff and things like that. So yeah, it's a challenge with these patients for sure, but you'll get a feel for it once you see it on rotations and whatnot. Anyway, so getting back to the ADHD meds, here we can see that our stimulants are going to be the first line drugs, and these mostly fall under the category of amphetamines. So just like crystal meth and all those sorts of products there, they all fit within the same family there, right? So again, we're going to see risk for things like chemical physical dependency and things like that can develop here, just like we saw with the opioids. And so there are going to be some challenges with this for sure. But we're going to see their mechanism here. They can work by blocking monoamine oxidase, so that helps to increase levels of things like norepinephrine. They can block reuptake of dopamine and norepinephrine. Again, this is the thing that leads to a lot of the physical and chemical dependence, is the dopamine blockade, or dopamine reuptake blockade, because it helps to trigger that reward pathway. That's where they get a lot of that euphoric symptoms or feelings from that makes them want to go back and use more of it. And it can also increase catecholamine release. So it seems kind of counterintuitive to have someone who is not able to focus on things give them a stimulant to make them, it seems kind of counterintuitive, but it basically helps them to focus. It helps to sort of make it easier for them to concentrate on task and stay on task for that period of time that's needed, basically. So it does seem kind of oxymoronic, but it does work. We're going to see here that patients will respond differently to different amphetamines. So you may need to switch between different products, which I'll show you the list here in just a moment. And then typically we like to use extended release preparations. With immediate acting drugs, you need to use them like 2 or 3 times a day, which is not ideal for school children who are having to go, and you don't want to have to send them with a controlled substance. It usually has to sit with a nurse. at school, they get disrupted from their day to go take a dose, so it's not ideal. So if you can use an extended release product, which most of them are, then you can avoid that. You can just give them one dose in the morning before they go to school, and then they're good to go, right? And keep in mind, you're going to see more adult patients who are being treated for this, either those that were children that have now graduated to adults and they still have ADHD, or now that have been newly diagnosed may require these as well. So I may kind of default to talking about school children, but certainly adults can be affected by this additionally. So one of the main products we're going to see here, this includes methylphenidate, includes dexmethylphenidate, mixed amphetamine salts, which is your Adderall, which is a combo of amphetamine and dextroamphetamine, and then lisdexamphetamine, which is kind of our newest one here, which is a prodrug actually that gets converted in the liver over to dextroamphetamine. You'll find a ton of different brand names for these because they have different dosage forms. Some come as liquid, some are long acting, some are immediate acting. But these are the main ones you're going to run into here. They're all going to be C2 drugs, so keep in mind that's going to put a damper on how much you can prescribe. Typically, what you're going to find is that since you can't give refills on C2s, you will, once you get a patient kind of on a stable dose of a drug that works well for them, the max the law allows you to prescribe for a C2 is up to 90 days worth. And then it allows you to split that up into 3 separate scripts. And what you'll find most commonly done is that you'll have, one script that says, you can fill today for a month's worth, so typically 30 pills or whatever. Then the next prescription will say, do not fill until 1 month later. And then the third script will say, do not fill until 2 months later. You'll put the specific date on there. And so that way they don't have to come back to you every single month, which is, good from the patient scheduling sort of standpoint there. So that's one benefit. But again, these are pretty highly restricted. So, no refills are allowed on that. And of course, under a lot of scrutiny from the DEA and that. Some of the challenges you see here is that these are stimulants, right? So things like reduced appetite and weight loss, which you would see with adult patients, just like you do with kids, not as great for kids because, typically they're still growing and you want them to be able to get enough nutrition to, supplement their developing bodies, right? Insomnia, irritability, tachycardia, hypertension, these are all things you expect to see just based off the mechanism of the drug there. And so again, if they have a history of hypertension, you got to make sure you're monitoring for that, things like that. As well, it does have a black box warning. All of them carry this for things like exacerbating psychotic episodes, hallucinations, abuse, and dependence. So just be aware of that. And again, I've seen a lot of sad cases of kids who, all throughout their primary school sort of time from grades K through 12, basically, they're on these amphetamines, and all of a sudden they decide not to go to college, and their providers just cut them off from the stuff cold turkey, and it's that can be really bad because that leads them to more addictive sort of patterns of use because they still have this physical dependence, and all of a sudden you cut them off cold turkey because you didn't think they have a need for it. There's been a lot of sad cases like that. They're really challenging. So just be aware they do have a high abuse potential. I'm sure most people have seen, especially more in rural areas, especially in Florida, you'll see quite a bit more amphetamine use, and so this can be started by things like for ADHD. You also find a lot of withdrawal effects from this. And this is typically the opposite of what you might expect from a stimulant. And so you're going to see they're kind of, very low energy and a lot of fatigue and whatnot. So they don't have the same sort of withdrawal effects like you would see from an opioid or a benzo. But again, these are usually a little bit safer. But they'll still have that craving. They'll still have that physical dependence where they want to get back to what their normal is. And that's where you get those addictive sort of patterns developing. And again, as I mentioned, that kind of concern for growth stunting, it should be minimal in most kids, but if you can provide drug-free trials, typically during the summertime when they're at home, that can be beneficial. Although parents want them medicated throughout the year, who knows? But that can help out with some like growth stunting concern. In terms of non-stimulants, so let's say you had someone who had ADHD but had a history of substance use in their past. You can utilize a non-stimulant like atomoxetine or Strattera. This is actually pretty similar to the SNRIs that we looked at before, like duloxetine and venlafaxine. This is actually approved for adults. So for a long time, this was used more commonly than your amphetamines just because concern for things like addiction were worse for adults. Now, this is going to have a lot slower onset than your amphetamines. Your amphetamines kick in pretty much immediately versus this may take a couple of weeks, just like we saw like the onset for depression. But the benefit here is there's no abuse potential. However, you do want to watch for things like hypertension, tachycardia, that history of hypertension can be worsened, liver injury, and this will carry similar black box warning for suicidal ideation, just like the other antidepressant drugs we looked at previously. Now, you can also do the opposite. So instead of giving them a stimulant to try to help them kind of hyper focus on something, we can try to give them something that kind of chills their brain out a little bit and kind of decreases some of the sympathetic actions of the body, sympathetic nervous system, I should say. And this includes two alpha 2 agonists. So this includes guanfacine and clonidine, which we looked at previously in terms of its use for hypertension. And so this is thought to help out with kind of preventing more catecholamine release, helping out some of the hyperactivity, and maybe some ability to help out with blood flow to the prefrontal cortex, or maybe it helps out with memory. This will not be as effective as stimulants. And honestly, what I see this used most frequently for are kids who are getting stimulants during the daytime, and then by the time it's nighttime, it's time to go to bed, they have horrible insomnia, and then they treat it with something like this because these drugs tend to be sedating. That's not ideal. I don't like the idea of using another drug to treat the side effects of the initial drug you started. However, sometimes it is what it is, and you have to add on additional medications there. So not ideal, but it can be seen. So you may use this as an alternative or in addition to some of your stimulant drugs. Again, watch out for things like hypotension, constipation, things like that. Treatment's going to be pretty well individualized. So again, you may have to kind of play with this and figure out which drugs you're going to respond best to. But think about things like the scheduling of it. Are they just, is one time daily better than getting it multiple times a day? They have comorbid conditions like hypertension? These are things you want to be looking out for. And generally speaking, you start with a stimulant, play around that category, unless you have some kind of contraindication, and then you can utilize non-stimulants like clonidine, guanfacine, and then for adults, I think a lot of people considered using atomoxetine for a long time, but I'm starting to see more and more use of amphetamine-based products for adults. It just depends on patient-provider sort of relationship and what they deem is best. And again, sometimes you maybe find their ADHD is a symptom of their anxiety or depression, so antidepressant therapy may be required there. That may be something where you get some additional benefit from something like an atomoxetine potentially. Anyway, so any questions on that as I get the next PowerPoint pulled up here? Question. Assuming you guys have it all down, you understand everything, and were you able to find the week? Are you able to get into the week now? I've not seen any other questions about that, so I'm assuming you guys can all see that and have the PowerPoint. So that assumption. But you know what they say about assumptions? You get you in trouble. But I'll talk about nephrology here. Basically, I'm going to kind of talk about this in terms of acute kidney injuries that happen and kind of focus on like drug-related causes for this, ways we can try to mitigate this, because this is a big reason for patients having acute decrease in kidney function. A lot of times it's because the healthcare providers did it. We either gave them medication or we're not monitoring it effectively, and we cause a kidney injury. And that's a problem. One, because, again, do no harm, right? But on the other hand, too, you have to think about it from a reimbursement standpoint. Insurance coverage, they don't want to pay you if you gave the patient an injury. So I'm going to find some ways we can avoid this. And then we're going to look at some of the chronic kidney disease issues that can pop up from patients who have long-standing kidney dysfunction, and some medications we can use to help treat that. So let's talk about acute kidney injury first. This is basically, we're going to see an abrupt decrease in kidney function. Usually we can identify this based on things like creatinine. Their BUN should be elevating, and urine output should be decreasing. And the reason why this is a problem is because there is a lot of morbidity and mortality associated with this, and there's no direct reversal for it, right? We don't have any ways we can just fix it, besides, maybe give them a new kidney, but that's not going to be ideal or feasible in 99% of cases. But our goals here are to make sure we're monitoring the hemodynamic status. If we can minimize the nephrotoxins they're getting, so we can discontinue offending agents and can switch them over to something else, highly ideal, but may not be possible always. Make sure we're monitoring their blood pressure, keeping that under control. Typically, it will rise as a result of kidney dysfunction. Fluid balance typically goes up in this case if they're not able to process fluids to the kidneys, and we'll look at their electrolytes as well to keep that under control. So there's different ways you can identify kidney injury. A lot of times you'll be looking at things like changes in serum creatinine or GFR. Again, GFR is calculated is estimated off of their creatinine clearance, which I think we've talked about briefly before. These are just some cutoffs that you'll see there. There's many different criteria available that kind of show you these. I'm not going to ask you specifically what type of kidney injury we're seeing here based off of the lab changes, but just for your knowledge, this is the things you're looking for. So typically, changes in serum creatinine, changes in GFR will give you an idea of how severe the dysfunction is. Here's another one here, the Aiken criteria. Again, looking for things like urine output. Typically for adults, we consider normal urine output to be between 0.5 and 1 ml per kilo per hour. You can go above that for sure, but anything less than 0.5 is not great. And then for children, typically we like to go above 1 ml per kilo per hour, and usually they can get much higher than that depending on the situation. But we kind of can break down acute kidney injury between community, hospital, and ICU acquired. You're going to see here that the incidence obviously gets more likely in very sick patients, so especially in the ICU. And we'll see here that especially with the hospital-based ones, that frequently it is more of an iatrogenic issue where we potentially have caused it, or it's related to things like septic shock, volume depletion, organ dysfunction, things like that. Typically on more the community acquired side, this is frequently seen with things like sepsis, dehydration, infection, more often than not, especially in elderly patients. The reason why I break those up into different categories is because you may find that the cause for the kidney injury may be different based on if someone's coming from the community versus they've been in the ICU for a month. You're looking for different reasons for why that's caused there. And basically, we can break down kidney injury into 3 different types. And again, depending on the type it is, you can have different causes for that. So the 3 main varieties we're going to run into is going to be pre-renal, intrinsic, or post-renal kidney injury. And this should be pretty intuitive based off their names here, but pre-renal means anything that's decreasing the amount of blood flow being perfused to the kidneys, right? So for instance, if I don't have enough blood to send to the kidneys because I'm hypotensive, because I'm bleeding out, because I just got into a car accident, that's a pre-renal problem. It's not that the kidneys aren't functioning well, it's just you're not sending enough blood to them. The intrinsic is going to be actual structural damage to the kidney, and this is where a lot of medications are going to cause problems, things like your aminoglycosides, right? And then post-renal is going to be any kind of obstruction leading to sort of a backflow problem for the kidneys, usually due to things like benign prostatic hyperplasia or due to like crystal formation in the urine collection system, something like that. I would tell you that the post-renal is probably the least common. These other 2 much more frequent you're going to be seeing in your practice there. And you can look at this picture here. Imagine the renal artery bringing blood to the kidneys. You're going to see anything that happens here before the glomerulus is going to be a pre-renal issue. Anything that happens within the actual nephron itself is going to be an intrinsic issue. So things like, tubular obstruction, things like glomerular injury, that's an intrinsic issue. And then anything afterwards, in the urine collection system is going to be a post-renal kidney injury. So again, you kind of imagine based on the location of the injury, kind of what's type of kidney injury this is. And so, and again, you guys are going to be the experts in terms of physical diagnosis and ordering the labs and doing your diagnosis and all that. You're going to be able to kind of figure out, okay, well, what am I looking at based off of the lab results and all of this? This slide is just to give you an idea of the things you might be looking for in terms of the causes for these different types of kidney injury. And I'll focus mainly on like the drug-induced causes and ways we can treat that. But certainly there are lots of other reasons for this. But you'll see this especially with patients who have like sepsis. You'll see this with patients with on certain medications and all that. It may cause different types of kidney injury, as we'll see here. Again, you can just refer back to this, but we'll talk about some of the more specifics going forward. So typically with community-acquired acute kidney injury, more often than not, this is due to renal hypoperfusion. So frequently this is due to things like volume depletion, like they've been vomiting, a lot of dehydration. Maybe they started up a new workout regimen in the middle of July in Florida, and they're outside doing a boot camp for 6 hours straight, and they're dehydrated, right? Sepsis can cause this too, because you get very leaky capillaries, you're third spacing a lot of fluids. But notice here that medications can be a big reason for this as well. So things like ACE inhibitors, diuretics, things we've talked about previously. For hospital and ICU acquired, this is more often going to be an intrinsic issue, or things like acute tubular necrosis being pretty common. So some of the risks we can see here for chronic kidney disease and decreasing GFR, you're going to see here that some of these are reversible, some of these are modifiable, some of these are not modifiable. So things like a patient's age, race, things like that, we can't really do much about, right? But certain things we can do, for instance, things like nephrotoxic medications. If we get rid of those nephrotoxic drugs, that's going to be a benefit to our patient. Now, can you always do that? Not necessarily, but ideally, you would like to be able to switch them over to something that's less nephrotoxic in order to help mitigate some of those issues. I wish my green screen app was working a little bit better because I'm getting weird artifacting here, but if I just move my head like this, it should be fine. But ink in my neck. So as I mentioned with the pre-renal, this is due to hypoperfusion. Patients don't have to have hypotension, but it's usually due to some decreased amount of blood flow going to and being filtered through the glomerulus. So this is frequently seen with like dehydration, so either due to like GI losses or hemorrhage, due to sepsis, or what you can see with things like hyperperfusion without hypotension. This is oftentimes due to things like renal artery occlusion. This is also where we're going to see with like our NSAIDs and ACE inhibitors. They are decreasing the amount of blood, pressure at the glomerulus that allows for the filtration to actually happen. That can be another cause for a pre-renal sort of problem there. And again, typically your kidneys are pretty good at responding to pre-renal problems, the hyperperfusion, because they can activate things like the renin-angiotensin system. It can, increase antidiuretic hormone release. It can do all of that. However, you're going to find that this can be overwhelmed, especially if medications are involved, especially if this is multifactorial. So you can overwhelm the system and cause hyperperfusion to occur. Functionally speaking, here you're going to see that with the NSAIDs and the ACE inhibitors, think about their mechanism and how they affect the kidneys, and you'll understand how they can cause a pre-renal kidney problem. So, for instance, normally prostaglandins keep the afferent arteriole open that allows for blood to come into the glomerulus. If you get rid of those prostaglandins by giving someone an NSAID, you clamp down on that vessel, and thus less blood flow gets sent to the kidney, less of it gets filtered, and thus you're going to have a decrease in GFR, right? Things like ACE inhibitors that are going to allow for the efferent arteriole leaving the glomerulus is going to cause it to open up, because normally Ang2 clamps that down. If you give an ACE inhibitor, you lose that, and then you're going to lose pressure at the glomerulus unless filtration actually happens. That makes sense, right? Or if we're giving someone like a vasopressor, we'll talk about this later, but things like, epi drips and dopamine drips and norepi drips, they cause vasoconstriction. And again, your body will, if it's in a really dire state, will preferentially send blood to the brain and the heart. Places like the GI tract are going to take a backseat to that and may become hypoperfused. The kidneys tend to be hypoperfused too in those cases there. So you can see a lot of cases where we may be inducing this by giving them certain medications. However, we may not have an option. We may not have a lot of alternatives there. So generally speaking, if you can catch and identify pre-renal acute kidney injury, it's pretty reversible. It's only when you have kind of prolonged hypoperfusion of the kidney, prolonged reduction of delivery of oxygen to the kidneys, when you get the intrinsic damage done. If you can catch it, reverse it, you will not see any long-standing effects there. Now, intrinsic damage can happen throughout any part of the nephron, from the glomerulus all the way down, and you'll find that different drugs or different conditions may lead to different types of injury. I'm not going to get super in the weeds in this in terms of what type of drug causes which type of effect here, but we'll kind of look at some kind of prototypical examples here. Typically, tubular damage is going to be the most common that you're going to see here. About 85% acute kidney injuries are actually due to acute tubular necrosis. So actually, necrosis, dying of the cells of the tubular cells there in the nephron. Half of this is probably due to renal ischemia, as I mentioned before. That kind of long-standing hypoperfusion can lead to the acute injury because basically you're not delivering enough oxygen to the tissue. The other reasons why you may see this include things like contrast agents, like sending someone to the CT scanner with contrast. That can cause a contrast-induced nephropathy. The aminoglycosides we talked about previously. Imagine someone has neuroleptic malignant syndrome, and all of a sudden they start to release a bunch of myoglobin because they're in rhabdomyolysis. Well, all that gets filtered, clogs up the kidney, can cause an acute tubular damage, right? So a lot of reasons for this. And again, the kidneys are very highly oxygen. They require a ton of oxygen because they have so many transporters they're working with. And so even though they're small and they don't really seem like a decent part of your body weight, they still require a lot of oxygen. And so by depriving it of that, that's where you see a lot of this acute tubular necrosis come from. So typically what you're going to find is that some sort of ischemic injury will start to cause necrosis and apoptosis of those cells there. The next problem that happens is now that these cells are dying off in the renal tubule, it can't really regulate fluid and electrolytes, right? So things like the loop of Henle can't reabsorb sodium like it's normally supposed to do. And that leads to a lot of things that should be reabsorbed just starting to leak out. It's going to be eliminated through the urine. And so you can see things like, hypokalemia, hyponatremia, because you can't regulate your electrolytes very well. You also won't be able to regulate things like your urine output. So you may start to hold on to too many fluids. Now you have edema that are developing. And so again, the sooner you can catch this and reverse it, the less damage is going to be done in the long term. And it hopefully is going to be reversible. You may find that's not going to be possible in some cases, and some patients require lifelong dialysis. But post-renal cases are pretty rare for the most part. This is more often due to things like BPH that can develop these patients here. So the prostate gets very enlarged and can impede on the urethra, impinge on the urethra, and prevent urine flow, which causes a backflow issue to the kidneys. It could be due to things like oxalate crystal deposition with certain drugs. This is uncommon, so I'm probably not going to focus on this too much. But certainly, if you work with like cancer patients, this may be an issue if you induce something like tumor lysis syndrome in someone who has, say, leukemia, and you give them a chemo drug, and all of a sudden these cells start to die off. That can sometimes be a problem. So, what are we doing here when monitoring these patients here? Certainly looking at their chronic conditions. A lot of things like hypertension, diabetes can lead to kidney injury. Looking at their labs, obviously urinalysis can be very helpful. Chem7 can be useful here. Looking for things like procedures or surgeries that may have led to kidney hyperperfusion. And certainly asking about their medications, not only prescription ones, but also OTC, herbal, recreational drugs. Patients may not be all that forthcoming with you for some of this, but you still want to ask the questions and figure out what's going on. Certainly a lot of recreational drugs like certain amphetamines have led to some issues of kidney injury before for sure. A lot of stimulants can do this, so definitely want to ask the questions at least. And trend the data too. I can't tell you how important it is to have historical data to help guide you in your decision making. Because I run into this all the time when I'm taking call for the poison center. Is a provider will call up, they want a recommendation on how to manage a patient, and they will say, okay, well the patient's creatinine is 2. It's pretty elevated, and I'll say, well, is that new for them or is that old? Because if that's an old finding, if they have long history of chronic kidney disease, that means something very different than if it normally sits at like 0.8 and now they're at 2 now. That's an acute problem we're dealing with now, and we gotta need to identify what the cause for that is. So again, having an idea of the trend of the laboratory data is always helpful. It may not always be available, but it's helpful. So serum creatinine is something that we use a lot of times to estimate creatinine clearance, which we used as a surrogate for GFR, because most of the time we don't actually measure GFR directly. We just use creatinine clearance. And so a lot of times I'll use the two interchangeably because that's really the best way that we're going to be estimating, or the most common way, I should say. There's limitations to using creatinine because this can vary a lot with the age and gender of the patient. If you consider an infant versus an adolescent versus an adult versus an elderly patient, they may have vastly different amounts of muscle mass. And again, creatinine comes from breakdown of the muscle. So if they have low muscle mass, then they can't produce as much creatinine as someone who has a lot more muscle, right? Diet can affect this. High protein diets can increase creatinine levels, hydration status, amputations. If someone has an amputation, say bilateral below the knee amputations due to complications of diabetes. I know diabetic patients are going to have renal insufficiency, but if they don't have enough creatinine produced because they have less muscle mass, then they may have a falsely low creatinine level, and that may overestimate what their renal function is, right? But if they had such poorly controlled diabetes, they had their legs amputated, chances are their kidneys are not doing well, right? It's just a matter of fact with the disease state and how it progresses. So you have to be careful there and make sure you kind of take into account the patient's situation. Not just look at the number, look at the patient, right? Physically, it can clue you into some stuff there. Not only that, but serum creatinine can kind of lag behind the actual true GFR by a couple of days because it takes time for it to get to a new steady state. So from that standpoint there, you'll find that estimations that just look at creatinine clearance alone may underestimate the GFR. So you gotta be careful there. Here's what this looks like. So if you imagine the actual GFR, if you could calculate that directly, you can see an insult occur here. You notice this drops down pretty much immediately, versus serum creatinine may take a day or two to really reflect that rise. So instead, what you can do in the meantime is look at things like their urine output. That can be really useful. So if all of a sudden they're going from, say, urine output of 1 ml per kilo per hour, and all of a sudden it dips down to, say, 0.3 mLs per kilo per hour, that's a pretty big drastic decrease, and you investigate that to see what's going on from that standpoint. So those are things you kind of want to think about when trying to look at a patient's creatinine clearance and try to estimate kind of what's happening from that standpoint there. Anyway, so with acute kidney injury, if you can predict it and you can potentially avoid it, which is helpful there. So, for instance, if you know a patient's going to surgery or they're getting contrast dye, making sure that they have enough fluid on board, making sure you're not taking someone dehydrated into the CT scanner to get dye because you know it's going to cause potential for injury. Making sure they have good fluid intake is important, and avoiding nephrotoxic meds at all costs if possible, right? So they don't need to be an aminoglycoside. You could switch them over to something like fluoroquinolone that may be reasonable depending on other patient factors as well. And again, ideally, you want to be able to screen, identify these patients, monitor until the risk has subsided, and make sure you're just making sure to adjusting medications, monitoring electrolytes, all of that while the risk is there, and then implement preventative strategies if you can, right? And so this is one of the biggest things I did, at least on my time in the ICU when especially on rotations and during fellowship, is just going through the patient's med list and comparing it to their creatinine clearance because it would change from day to day. And so it's very frequent you have to go in and say, okay, we're going to adjust this down, we're going to adjust this back up, so really making sure to take a look at that and think about all aspects of that patient, how their renal function may be affecting them is super important. So hydration is probably the biggest thing that shows effects in terms of benefits in preventing acute kidney injury. And so fluids can sort of be broken down. We're mainly focusing on IV fluids here, not PO necessarily. So you can kind of break them down into crystalloids and colloids. Those are the two main distinctions. Most of the time, you're going to be dealing with crystalloids, and this includes things like your normal saline, lactated ringers, and whatnot. And this is by far and away first line. 99 times out of 100, you're going to be using this to help replete intravascular volume and prevent dehydration, prevent renal hyperperfusion due to volume. Colloids are going to be things that are either like starch or protein based, and these are going to be typically more expensive, and they can actually cause renal dysfunction themselves. So these are not going to be ideal for a lot of these patients here. So that's one thing to note. I'll talk about them briefly here, but for the most part, these are going to be things that are used as like replacement for something the patient's missing, like albumin, for instance. Now, when I say crystalloids, again, these are salt-based products here. So, for instance, like normal saline, which is sodium chloride, is the most common one you're going to run into. And so, when I say normal saline, what that's referring to is 0.9% NaCl. Okay, now 0.9% may not mean much to you right now, but here's why we call this normal saline. Basically, that 0.9% means that for every 100 mLs of water, there's 0.9 grams of sodium chloride, right? When you break that down, that means that you have 154 milliequivalents per liter of both sodium and chloride, okay, because it's a 1-to-1 ratio between the two there. So when it breaks up into solution, it dissociates and it has an osmolality of basically 2 times 154, which is 308. So why is this important? Well, one, our normal serum sodium is between 135 to 145. This sodium in this bag of normal saline is 154. So it's higher, but it's pretty close to what our normal serum sodium is. So okay, that's close enough. And then the osmolality, as I mentioned, for that bag of normal saline, that liter, is 308 milliosmoles per liter. What do I say here? Per liter, not per kilogram. For here, the serum osmolality of our blood, our serum, is normally 275 to 295. So 308 is pretty close to 295. So because of this, it's close to our normal serum osmolality, close to normal serum sodium. This is considered isotonic, considered normal saline because it kind of mimics closely what's in the blood. Okay. Again, normal saline, 0.9% is not the only one you're going to use. If you see a half normal saline, that means 0.45% NaCl. That would just be half of that. So 77 milliequivalents of sodium and chloride there. You may see quarter normal saline, which is 0.22%. So this is a good number to keep in mind because you can figure out how many milliequivalents per liter there are based off if it's normal saline. You'll see some stuff like D5 being used, and while D5W itself is isotonic, it's pretty close to the serum osmolality that we're used to. We're going to find that dextrose does not stay in the blood vessels very long. It gets uptaken into the cells for energy use. So we consider that to be free water, meaning when something is isotonic and you put that fluid into the intravascular space, that fluid basically stays there. It doesn't really go out into the tissues. It doesn't draw water into the vascular space. It just stays right there, right? Isotonic. But something like D5W being used by itself, that's all free water. I mean, all that water is not going to stay in the vascular space. It's going to go out into the tissues, which may not be good if your patient has like edema or something like that.
So that's why you typically don't see D5W being given as fluids by itself. You'll see something like NS, D5W together. And that way the patient's getting some sugar, they're getting their normal saline, they're getting isotonic fluid. So from that standpoint, that's why we do that most often. So for someone who's dehydrated, you wouldn't give them a liter of dextrose because that's just all free water. It's not going to help out their blood pressure that's tanking. You give them a normal saline bolus, right? Oh, that makes sense, but if it doesn't, let me know. Um, Now, treatment for acute kidney injury, other things we can do can include things like eliminating the insult, supportive care, managing their electrolytes and whatnot, and utilizing things like renal replacement therapy if needed. So when I say RRT, this is referring to things like dialysis. This is obviously not ideal, and if you can avoid needing dialysis, that is always a good thing. So you don't want to require that because it's um, pretty labor intensive, and to get the nephrology guys involved, and it's, if you can avoid it, it'd be great. Most of the time, though, if you can eliminate the insult, it should recover within about 2 weeks or so. But again, it may not always be the case. You may have to continue using that aminoglycoside. You may have to continue. The patient may stay hypotensive for a while. So those are things to really consider there. As I mentioned with the dehydration, you can get them fluids. If you can give them oral fluids, that's great. That may not always be feasible, especially if they're having GI issues. So we can utilize isotonic IV fluids there. So for instance, using 1 to 2 liters of normal saline for most adults will help to replete their intravascular volume, right? But if they're septic, they may require more than that, right? I think some patients need like 6 to 8 liters of fluid there. But usually usual dose for like kids would be like 20 mLs per kilo typically. So that's a good number to have in mind if you want to think about what a normal bolus is for a patient. The goal for a lot of these patients are to keep their mean arterial pressure above 65 millimeters of mercury, right? MAP can be calculated by taking 1/3 of the systolic blood pressure plus 2/3 of their diastolic, and that gives you your MAP. And around 65 is considered normal. And then you want to keep their urine output up. So anything above 0.5 mLs per kilo per hour is considered to be sufficient there. And of course, you're looking for things like edema. You're listening to the lungs to see if you're starting to get some crackles there, indicating fluids building up, electrolyte balances, normal glycemia, all those things you want to be looking for, especially. So for patients who are like anuric or oliguric, you want to use smaller volumes. So maybe be a little bit more gingerly with your administration of fluids. Maybe 250 mLs, 500 mLs is fine. And you want to be careful giving too much normal saline because, again, that 154 milliequivalents of chloride per liter of normal saline is a lot higher than what our normal is, which is usually in the 1 teens. That can cause a hyperchloremic acidosis. In those cases, there we'll either switch them out to something like lactated ringers, or we might try to utilizing half normal saline plus some sodium bicarb added in there. Just depends. And then obviously, if they are hypotensive because they're bleeding and they're losing a lot of blood, then yeah, give them a blood transfusion. I'm not going to get super in depth on that because it's kind of outside of my wheelhouse, but you'll see that a lot in trauma patients. So, in terms of renal replacement therapy, so again, hemodialysis, you'll see there's different strategies for this, whether it be intermittent or continuous. The most common indications for using dialysis for these patients here is a handy mnemonic, so you have the vowels here. Basically, you're looking for things like acid-base abnormalities can be fixed with this. Electrolyte imbalances like hyperkalemia, hypernatremia, intoxications, so things like aspirin overdoses, lithium overdoses, I recommend for some patients when I'm on call. Fluid overload, you have to pull more fluid off the patient if need be, and then uremia. Those are the most common reasons patients may require hemodialysis. So, things you want to consider when a patient does have acute kidney injury, so that say their GFR has dropped by 50%, making sure you're looking at things like the volume of distribution for these drugs, looking at the volume stats to see how well hydrated they are, and looking at the antibiotics they're taking, especially for those septic patients, and consider changing the dose. Sometimes we need to give a drug less frequently. Sometimes we need to give a drug at a lower dose. It just depends, but it's on a very case by case basis. You want to monitor for that. So, for instance, you may have a patient getting, gentamicin, 24 hours, and all of a sudden they have kidney injury. Now you may need to back it up and give it every 36 hours, every 48 hours. So those are things you want to be looking at. And again, there's no actual drug or treatment you can do specifically to treat the acute kidney injury. So prevention is always, worth a lot more than the actual, because we don't really have a cure for it. So if you can prevent it, that's always going to be most beneficial there. Some people try different things for treatment of acute kidney injury, but they don't really have a whole lot of consistent effects. So some people have tried like loop diuretics. This is really only going to be useful for patients who are fluid overloaded. It doesn't do anything, even though the urine output goes up. makes sense, but it doesn't actually do anything to the actual function of the kidneys itself. It just makes you lose more fluid. So helpful for patients who have edema related to acute kidney injuries. Um, Lasix is probably used most commonly, pretty well tolerated, it's cheap. However, if you have a sulfa allergy, you might want to avoid that one. That's where we usually use ethacrynic acid. Any of these would be totally fine to use for patients here. Um, Frequently, you're going to find, especially with patients with acute kidney injury, will develop what we call loop resistance, where your loop diuretics look like they're working for a while, but then all of a sudden they seem to become less effective. So we can do things like giving them parenteral loop diuretics. We'll use continuous infusions, or actually what we can do is to utilize a second diuretic that works at a later part of the nephron. So instead of working at the loop of Henle, we can go and maybe use something like thiazide that works at the distal convoluted tubule, and that helps the drug to work that much better. You get better synergy there. It helps the loop to be all that much more effective there. And again, reasons why you may develop this resistance here can include things like high sodium intakes. You may find that patients just have less working nephrons to process the fluid through. You may find some renal compensation at the distal tubule. Again, that's where that having a thiazide on board can also help with that for sure. Just remember for your thiazides with loop resistance that a lot of them lose efficacy once your GFR starts to dip down below like 20 to 30. That's where metolazone is supposed to be used there. That's the one thiazide diuretic that retains activity even at very low GFRs. That's something line with that one. Drugs you could use at the collecting duct would probably be some of your potassium sparing diuretics. This is not used as commonly. More often than not, a thiazide is going to be pretty effective here. In terms of electrolyte management, certainly look at their sodium. If you can limit sodium intake, that can be one reason or one thing you can do to help out with that. And if your patient is on renal replacement therapy, that will usually regulate most of their electrolytes. Everything except for magnesium and phosphate can be pretty well managed with dialysis. Certainly hyperkalemia can be fixed pretty easily with that. Keep in mind though that patients with hyperphosphatemia, this can happen with like trauma or rhabdomyolysis, things like that. You don't want to give them any more calcium because phosphorus and calcium tend to bind up together and can cause tissue calcifications and things like that. We'll talk more about that in the chronic kidney disease here in just a little bit. But what's also the kind of the double-edged sword there is that patients on renal replacement therapy can develop hypocalcemia. And why is that? Well, basically, when you have a patient on dialysis, you're taking a large amount of their blood out through a cannula, processing it through the dialyzer, and then sticking it back into the patient. When it's going through all that plastic tubing, you don't want that blood to coagulate off because then it'll clog up the system and the dialysis is not going to work. So what we do is we give them, again, if you look back at our anticoagulant section, you'll see that calcium is really important for kicking off a lot of the reactions in the clotting cascade. By giving a drug that will bind up that calcium in that circuit, of the dialysis circuit, something like a citrate anticoagulant, you'll bind up that calcium and prevent the blood from clotting. However, you bind up that calcium, so by the time you put it back in the patient, there's less calcium there. So oftentimes they will need calcium replacements during dialysis. So that's something you want to consider there. But again, make sure just monitor these electrolytes and kind of adjust as need be there. So those are the big things we can do for acute kidney injury here. Now I want to kind of more shift gears and then focus on how we manage patients with chronic kidney disease, whether this has occurred through long-standing hypertension or diabetes, or maybe the result of, say for instance, someone who had acute kidney injury. Now this is now developed into a chronic problem. How can we help these patients out? And again, you can see it can be categorized based off of their GFR and how diminished it is, all the way down to end-stage renal disease. Again, I'm not going to have you tell me on a test which category someone is based off their GFR. You can always look that up. I don't really care that you know that for my purposes. What I do care that you know is understand a lot of the complications of chronic kidney disease. So things like more likelihood for bleeding that can occur with these patients here. So things like platelet dysfunction, knowing that they can find endocrine dysfunction here as well. We'll talk about this in diabetes, but insulin is cleared through the kidneys to some degree. And so when you have less clearance through the kidneys, you're going to find insulin sticks around and cause hypoglycemia. GI effects, you're seeing neurologic effects, things like neuropathies and encephalopathy that can develop here. So these are things we're going to try to manage with some of our medications in order to treat CKD. Probably the biggest reason you're going to run into this is going to be diabetes and hypertension, but certainly other things that can, increase their risk include things like, smoking, obesity, etc. And again, so probably the first step in managing patients with chronic kidney disease is managing their other metabolic conditions first. But you're going to see that over time, we're going to have this loss in nephrons. And again, you have two kidneys, and they do provide quite a bit of support, and they will stay, even if you do have a significant reduction in overall number of functional nephrons, the patient may look like they have a normal GFR. Once they start to have evidence of decreased GFR, you're kind of too late in a lot of cases there. So a lot of things we're going to try to do are to prevent further damage to the kidneys and try to retain as much function as we can, without the need for something like a transplant. So basically what we're going to see here is you'll have some sort of initial injury. You'll find that basically you'll have an acute decrease in GFR, and that leads to a lot of hemodynamic changes. So things like increase in the renin-angiotensin system. And you can see this sort of feedback loop that happens here, which causes, again, severe systemic hypertension, and then feeds right back into the reduced GFR. The diabetes can also wear out the kidneys over time and lead to reduced GFR. So it's kind of a cycle that happens here. So we're going to try to interrupt this by getting things like their hypertension fixed, fixing their diabetes, and trying to interrupt this system. That way we can retain as much kidney function as possible, right? So I want to talk about some of the chronic diseases they're going to run into when they have chronic kidney disease. So first off is going to be anemias. So this is basically because the kidneys are the main source for production of erythropoietin. And so you can see a big decrease in the number of or the amount of erythropoietin they're generating with chronic kidney disease. Not only that, but you do have a lot of iron deficiencies that can happen here. So mainly this is due to either like frequent blood testing or renal replacement therapy with blood loss associated with that, or they'll just have decreased GI uptake. And again, one of the big things you're going to find here is that in order for erythropoietin to work, you have to have iron around to make that hemoglobin. It doesn't matter. You can give as much erythropoietin as you want, but if they don't have good iron stores, it's not going to be that effective. And so we're going to see that's going to be a really important aspect of that. You're also going to find that CKD is related with a lot of bone and mineral disorders. This is as a result of the fact that they cannot produce active vitamin D because vitamin D gets activated in the kidneys, or the second final activation step happens in the kidneys. So they have less vitamin D. You're going to find they have a harder time processing calcium. And not only that, but it's going to bind up with phosphates. You have kind of a hypocalcemic effect here. And overall, you're going to have higher PTH levels, parathyroid hormone levels. What that's going to do is going to lead to a balance towards the osteoclast activity. You're going to have a lot of bone being taken up. And that's going to lead to this condition called renal osteodystrophy. Risk for osteoporosis is going to go up. So again, we're going to find some ways we can try to interrupt this cycle as well in order to prevent that from occurring. Basically, what's happening here step by step is that when you have decreased renal function, you're going to have an increased level of phosphate because you can't process it through the kidneys as well. That phosphate then binds up with calcium, and so you develop hypocalcemia as a result of that. So having less vitamin D and having or activated vitamin D and less calcium leads to increased levels of PTH. What does PTH do for us? Well, it actually increases calcium and phosphate reabsorption from the kidneys, which is just going to make our problem worse. Not only that, but the osteoclasts are more active, and that causes more mobilization from the bone. So you can start to see now that because we have this deficiency of calcium and vitamin D, PTH levels are going to be elevated. And again, we need to find some way to try to interrupt that and prevent them from having worsened osteomalacia, osteoporosis, all of that. And again, you can see how this is a sick cycle here that will just kind of keep perpetuating itself. Again, I'm not going to get super in the weeds on this, but just know it's because you have less vitamin D, you're having less phosphate being excreted, that's binding up a lot of your calcium, causing hypocalcemia. Low calcium, low vitamin D means more PTH, means more uptake of calcium from the bone. Okay. So renal osteodystrophy. And so what you can see with that, it's going to be things like parathyroid hyperplasia, which actually makes it even more resistant to calcium and vitamin D. And so again, you can get this high turnover bone disease called osteitis fibrosis cystica. And that's going to be affecting your bone marrow fibroblasts as well, and decreases even more erythropoiesis. So again, you can see how these things kind of compound on one another pretty quickly there. You also see some uremic symptoms that can happen here, things like altered mental status, weight gain, edema. You see that foaming urine due to the proteinuria they're experiencing there. So a lot of different problems that can happen here. So again, the goal is to try to save what renal function we can. If we need to supplement renal function with things like dialysis, we may need to do that and help out all the other metabolic stuff. So if we can get their calcium taken care of, their vitamin D taken care of, get their anemias under control. That's overall going to be helpful in the long term for these patients here. So as I mentioned, delay or prevent further progression of disease. Try to limit the need for hemodialysis or peritoneal dialysis. That's HT and PD. Again, those are labor intensive. They have a lot of risk associated with them. So the longer you can go without needing something like dialysis or transplant, the better off your patient is going to be. Again, you want to diagnose or address those primary concerns like the hypertension and diabetes, which is so common in these patients here. Now, when I talk about dialysis, I kind of alluded to it back in the acute kidney injury thing, but typically with chronic dialysis for these patients here, and if you're not familiar with it, if you are, then this is just repeat. But real briefly, with hemodialysis, this is typically where like a patient may have like a fistula or a cannula inserted into the arm. If it's a hemodialysis catheter, it's usually going to be in the femoral vein or something like that. But basically, there's different types. But ideally, you're taking blood out of the patient, running it through this dialyzer, and here's a filter here. They can process things like fluid, electrolytes, and whatnot, and then you put it back into the patient, basically. Again, that's where I talk about losing blood here, losing calcium here, because you have to have an anticoagulant. And basically, this patient will have this done for chronic kidney disease 4 hours, 3 times a week, right? And so Monday, Wednesday, Friday typically are pretty hopping at the dialysis center. Come for 4 hours. And again, that's pretty disruptive. I mean, if I had to imagine trying to find 4 hours for anything nowadays, with my kids and all of that, it would be almost impossible, right? And so non-compliance can be a big challenge for these patients. We'll typically have dialysis patients who skip their Friday dialysis and they come in Sunday feeling miserable and their potassium's through the roof and all of that, so it can be a big challenge. On the other hand, there's something called peritoneal dialysis, where basically you have a dialysate solution that can be infused in the peritoneal space. There's usually a catheter that will be placed here, and this will just be allowed to sit for a period of time, so maybe a few hours, depending on the regimen. And basically this re-equilibrates with the waste products here in the bloodstream, and basically it just comes out as urine, essentially. So to be able to pick up that fluid or all those waste products, and then you can eliminate it out. And so you'll pump in the fluid, let it sit there, take it back out, and then you'll pump in some again. And so you'll see this exchange time will vary depending on the patient, but they'll have a certain number of exchanges that happen here. So you put it in, wait for 30 minutes, pull it back out, put some more in, pull it back out. And it takes a few hours for that to occur there. So that's the difference between the two here. Typically, hemodialysis is much more like kind of 4 hours. You're sitting here, you're doing this thing. Whereas with peritoneal, it can be much more, maybe less labor intensive for the patient, but it's still pretty disruptive. So, it's 9:30 here. I have another meeting I'm going to get it to, and I'm actually doing pretty good on time. So I think I'm going to hold this off till the next meeting, which is, I think, what are we talking about next week? I think we're talking about urology. So this will actually segue pretty well into the urology section. So I think I'm going to go ahead and cut it off here. And then we'll finish this section up, and then we should be able to get right back on track next week with urology. So I think we're good to go from that standpoint. Do you all have any questions I can answer before I let you go? Oh, thank you for whoever gave me the like. I appreciate that. Very nice of you. I recently hit 600 subscribers on YouTube, which is really nice. If you're one of the people that did that, I appreciate you. Any questions at all? Anything on the board? Again, I'll either assume that your brains are leaking smoke out of your ears currently, or that I did such a good job that you have absolutely no questions. And there's zero in between those two situations. I'm just going to assume it's one of those two. Player on the side of I was just an awesome teacher. No, so please, if you do have questions, either post them up on the board. We'll get to them next week, or you can email me. Either one's fine. And then otherwise, I will see you all next week. So thanks so much for joining me, and I will see you then. Sorry for my head's been doing something weird. I promise that's software issues, not monsters or something. But, all right, thanks a lot, and I'll see you guys next time.